Picture this. A 34-year-old woman is sitting in her car in a parking lot, engine off, staring at her phone. She has 4 unread work emails she's been avoiding for 6 days. Not because they're hard, because starting them feels, for reasons she can't explain, almost physically impossible. She's smart. She's got a college degree. She's held down a job for years. And yet she cannot make herself open Outlook. She's not lazy. She's not undisciplined. And she's about to find out, at 34, that what she's been calling just how my brain is actually has a name. That's what this episode, and honestly, this entire course, is about. Here's where we're going to start, and I want to be upfront about it. We are not going to spend the next 15 minutes talking about hyperactive 8-year-olds bouncing off classroom walls. That image is where most people's understanding of ADHD begins and ends, and it's exactly why so many adults, especially women, especially high achievers, especially people who were quiet, spacey kids instead of disruptive ones, go 20, 30, sometimes 40 years without ever being told what's actually going on with their brain. So let's build this properly, from the ground up. Adult ADHD stands for Attention Deficit/Hyperactivity Disorder in Adults, and I know, even that name is a little misleading, and we'll get into why. It's classified in the DSM-5-TR, which is the diagnostic manual American clinicians use, as a neurodevelopmental disorder. Neurodevelopmental means it originates in how the brain develops, typically starting in childhood, not something that suddenly appears because your job got stressful or you had a bad year. That distinction matters, and we'll come back to it. Here's the clinical core of it. ADHD involves a persistent pattern of inattention and or hyperactivity impulsivity that interferes with functioning or development. Persistent is the key word. Everybody loses focus sometimes. Everybody's impulsive occasionally. That's being human. A DHD is when this pattern is consistent, pervasive across different areas of your life, work, relationships, home, and has been present in some form since childhood, even if nobody noticed at the time. Now, the DSM-5-TR actually breaks ADHD into 3 presentations, and this is genuinely important because most people only know one of them. The first is the predominantly inattentive presentation. This is the woman in the parking lot. This is trouble sustaining attention, difficulty organizing tasks, losing things constantly, seeming not to listen even when spoken to directly, avoiding tasks that require sustained mental effort, being easily distracted, no bouncing off walls, no visible hyperactivity at all. This presentation is quiet. It's internal. And historically, it has been wildly underdiagnosed, particularly in girls who often got labeled daydreamers instead of getting evaluated. The second is the predominantly hyperactive impulsive presentation. This is closer to the stereotype. Fidgeting, feeling restless, talking excessively, interrupting others, difficulty waiting your turn, acting without thinking through consequences. In adults, by the way, this doesn't usually look like running around a room. It looks more like an internal sense of restlessness, a racing quality to your thoughts, or a pattern of impulsive decisions, quitting jobs abruptly, interrupting people in meetings, impulsive spending. The third, and actually the most common presentation in adults who get diagnosed, is the combined presentation, meaning you meet criteria for both inattentive and hyperactive impulsive symptoms. Now here's where clinicians think about this differently than most online content does. For a diagnosis, The DSM-5-TR requires 5 or more symptoms of inattention and or 5 or more symptoms of hyperactivity. Impulsivity for adults. The threshold is actually 6 or more for children under 17, but it drops to 5 for anyone 17 and older, which itself tells you something. The field recognizes that symptoms often look different and can appear somewhat less numerous in adults compared to kids. These symptoms have to have been present before age 12. They have to show up in 2 or more settings, so not just at work, but also at home, or in relationships, or socially. And critically, they have to cause clear evidence of interference with functioning. Not just mild inconvenience, actual interference. That last part is where clinicians draw a hard line, and it's one of the most misunderstood aspects of this whole condition. Having some ADHD-like traits does not equal having ADHD. Everyone procrastinates sometimes. Everyone forgets where they put their keys occasionally. The diagnostic threshold exists specifically to distinguish ordinary human variation in attention from a disorder that is measurably disrupting someone's life. Let's talk about what's actually happening in the brain, because this is where a lot of the shame around ADHD starts to dissolve. ADHD is associated with differences in brain networks involved in executive function. Think of executive function as your brain's management system. It's what allows you to plan, prioritize, initiate tasks, regulate emotions, hold information in your working memory, and inhibit impulses. Research using neuroimaging has pointed to differences in the prefrontal cortex, the basal ganglia, and connectivity between brain regions involved in attention regulation, particularly involving the neurotransmitters dopamine and norepinephrine. These chemicals are deeply involved in motivation, reward processing, and sustained attention. This is not a character flaw. This is not a motivation problem in the way people mean when they say, just try harder. It's a difference in how certain neural circuits regulate attention and behavior. I want to say that plainly because so much of the suffering around adult ADHD isn't actually caused by the symptoms themselves. It's caused by decades of being told, implicitly or explicitly, that the symptoms are a moral failing. Now, let's clear up the attention deficit name itself, because it genuinely confuses people. It's not that someone with ADHD has less attention available, it's that attention regulation is inconsistent. Many adults with ADHD can hyperfocus, meaning they can lock onto something that's highly stimulating or interesting for hours, losing track of time completely. The problem isn't a lack of focus. It's difficulty directing and sustaining focus on demand, especially for tasks the brain doesn't find inherently engaging, like, say, 4 unread emails about a spreadsheet. Let's walk through 2 real-life examples, because abstractions only take us so far. First example. Marcus is 29, works in marketing, and has been passed over for 2 promotions. His performance reviews all say some version of the same thing. Great ideas, brilliant in meetings, but struggles to meet deadlines and follow through on details. Marcus has started 3 side businesses in the last 5 years, each abandoned within a few months once the initial excitement faded. He's been called scattered his whole life. What Marcus doesn't know yet is that this pattern, high initial engagement, strong creative thinking, followed by an inability to sustain follow-through on non-stimulating tasks, is a textbook adult ADHD pattern, specifically involving what's sometimes informally called the interest-based nervous system. His brain engages powerfully with novelty and struggles profoundly with routine maintenance tasks. Second example, Priya is 41, a hospital nurse, incredibly competent and well-regarded at work, where the environment is fast-paced, urgent, and constantly shifting. But at home, her house is chronically cluttered. Bills get paid late despite having the money, and she describes feeling like two different people depending on the environment she's in. This is actually a very common and clinically recognized pattern. ADHD symptoms can be substantially masked in high stimulation, externally structured environments like a hospital floor with constant urgency and clear protocols, while becoming much more visible in low-structure environments like unstructured time at home. This is part of why so many high-functioning adults go undiagnosed for years. The disorder doesn't disappear in structured settings, it just becomes less visible. Now let's talk clinical perspective for a moment, because this is where I want you thinking like a clinician, rather than like a social media caption. Clinicians do not diagnose ADHD based on a single behavior, a single bad week, or a single quiz result. We're looking for a developmental history, meaning, did this pattern exist in childhood even if it wasn't labeled at the time? We're looking for pervasiveness across settings. We're looking for functional impairment. Is this actually costing the person something measurable? Their job performance, their relationships, their finances, their self-esteem? And critically, we're doing differential diagnosis, meaning we're ruling out or identifying whether something else could better explain the symptoms. Anxiety, depression, sleep disorders, thyroid dysfunction, trauma responses, and other conditions can all produce attention difficulties that mimic ADHD. We're going to spend an entire episode later in this course on ADHD versus anxiety specifically, because that overlap trips up even experienced clinicians sometimes. Let's correct a few misconceptions right now, early in the course, because they'll keep resurfacing if we don't address them up front. Misconception 1. ADHD is just an excuse for laziness or lack of discipline. This one causes enormous harm. ADHD is a well-documented neurodevelopmental condition with decades of peer-reviewed research behind it, recognized by the American Psychiatric Association, the CDC, and every major medical body worldwide. The struggle isn't about willpower. Telling someone with ADHD to just try harder is a bit like telling someone with nearsightedness to just squint harder. It misunderstands the actual mechanism of the problem. Misconception 2. You either have ADHD or you're just distracted sometimes. There's no in-between, and everyone's a little ADHD. This one waters down a real diagnosis. Yes, attention exists on a spectrum in the general population, but clinical ADHD is defined by a specific threshold of symptom count, duration, childhood onset, cross-setting pervasiveness, and functional impairment. Not everyone who loses their keys has ADHD. The diagnostic criteria exist precisely to separate the disorder from ordinary human variation. Misconception 3. ADHD is a childhood condition that you outgrow. This is outdated. Longitudinal research has followed children diagnosed with ADHD into adulthood, and a substantial majority continue to experience clinically significant symptoms as adults, even though hyperactivity in particular tends to become less overtly physical and more internalized over time. The condition often changes shape. It rarely disappears. So what should you actually walk away with from this episode? First, adult ADHD is a real, well-researched neurodevelopmental condition involving persistent difficulties with attention regulation, impulse control, or both, that must have roots in childhood and cause genuine impairment across multiple areas of life. Second, there are 3 presentations: inattentive, hyperactive, impulsive, and combined. And the inattentive presentation, the quiet one, is the one most commonly missed, particularly in women and high-achieving adults who've built elaborate coping systems. Third, having some traits associated with ADHD does not mean you have ADHD. Diagnosis requires meeting a specific clinical threshold, which is why self-diagnosis from a TikTok video, while it can be a useful starting point for curiosity, is never a substitute for a proper evaluation, which we'll cover in detail in Episode 5. And fourth, this is not a character flaw. It's a difference in how the brain's attention and executive function systems are wired and regulated, and understanding that is often the first real relief people feel. Now, here's a question worth sitting with before we move forward. If ADHD is this well-documented, this well-researched, why does so much of what circulates about it online feel off? Why do so many adults say they learned more about their own brain from a 30-second video than from their doctor? And why do actual psychiatrists often wince when they see those same videos? That's exactly where we're headed next. In our next episode, we're going to put social media ADHD content under a clinical microscope. What it gets right, what it dangerously oversimplifies, and how to tell the difference. Because understanding what ADHD is only step 1. Understanding how it gets talked about and sometimes distorted is just as important.